When we think of dementia, first we think of the 4 A's, okay? Because although the first one is what everyone thinks of when they think of dementia, the amnesia, dementia syndromes affect the entire brain by and large. And so there are widespread deficits, but amnesia is certainly the most obvious early deficit. So patients have especially problems with episodic memory, working memory, laying down new memories is very difficult for these patients. So once the disease starts, they have an anterograde going forward memory loss. And as I've said before, it's much more prominent with short-term memory. So that is certainly the most prominent feature early on in the disease. But again, the whole brain is affected. And so the Wernicke's and Broca's area, the association cortex around that is involved in language, shrinks, basically. And so patients also have a shrinking of their vocabulary. They frequently will make some paraphasic errors. But the important here, the degree of language impairment is congruent with the degree of amnesia and other features of dementia. That's just important. If you have someone that's having some memory loss, but the aphasia seems out of proportion, well, then that would be not typical. Okay, so again, as I said earlier, patients with Alzheimer's, they use a less specific word for things, and just listen to them talk, and you'll hear some of those paraphasic errors. Okay, we've defined apraxia previously, but recall these are areas in the brain where you have laid down these motor programs. So you've used these motor programs hundreds of times already today for various things from, if you drove your car or rode a bike or you're typing or using a pencil or getting dressed. These are all motor programs that are laid down in the brain. And so an apraxia is where you have a disintegration of these motor programs. And so patients have more difficulty just doing anything like dressing. They used to be really fast typing, and now they kind of stumble with that. And so these apraxias are quite common. Remember that apraxia is something that is a previous learned task, right? But then it disintegrates. And so when you ask someone to do something like show me how you would flip a coin, or show me how you would salute. Obviously, if someone is paralyzed in their arm, they're not going to be able to show you how to do that, right? So the problem in an apraxia is not because of weakness, ataxia, or sensory loss. It's a disintegration of motor programs. I used to work with a neurologist who said he had a parallel parking apraxia because he had difficulty doing that. And I had to remind him that actually apraxia is where you have a previously learned task that you could do well, and then it disintegrated, and he never could parallel park. Okay, so agnosia. Now, I highlighted the M and the S here because if apraxia, we want to think of motor programs. With agnosias, we want to think of difficulty integrating sensory information. And again, just like apraxia, it's not because they're blind, right? It's a problem with the areas of the brain that interpret sensation. So we can have a variety of visual agnosias, like prosopagnosia. So patients with Alzheimer's have more difficulty recognizing faces just because that whole area of the brain is just not as robust as it used to be. So there can be a variety of others. Phonagnosia, I have a number of patients that just have a difficulty recognizing a familiar voice, even of a family member. Alexia can be more difficult, and time agnosia is actually quite common. So patients just do not do well, like you ask them, tell me, what happened yesterday? How long did you spend doing this? And then what did you do? So that kind of being able to incorporate the succession and duration of events during a day is impaired. And executive functions are also significantly involved. So patients with Alzheimer's, if they, for example, used to pay the bills and organize the bank account and pay taxes. The planning and organization that goes into that is impaired. And oftentimes you'll find, I like to ask patients that are having memory problems, especially if the spouse is there, if they pay the bills. And if not, what happened? And you'll usually get a story of, bills weren't getting paid, or they were getting paid twice, or, there was some issue there. Now, mild cognitive impairment is extremely common. So these are patients that are having some cognitive issues, but they don't qualify formally for a diagnosis of Alzheimer's. So they're at risk. So you can see, above, once you get to 70, 10% of patients have some mild cognitive impairment. So this can be the amnestic form, where there's just a little bit of forgetfulness, and a non-amnestic, which would involve more like a visual spatial, or more of like a word-finding difficulty, which, by the way, virtually everyone has as they get older. So this is such a common complaint. We're much more concerned about the amnestic form, where there's actually some forgetfulness. So these patients really are at risk of developing Alzheimer's, but you need to follow them, because if they're stable and not changing, over 6 months, over a year, then that is not Alzheimer's dementia. Alzheimer's always progresses. So overall, especially with the amnestic form, there's about a 50 to 80% chance of developing Alzheimer's over a 5-year period of time. So we're always trying to determine, is this just normal aging? Okay, because a lot of people are concerned, especially with word-finding difficulty, am I getting Alzheimer's dementia? And usually for that complaint, the answer is no, but you need to follow patients. So I put this in here years ago. I spent a whole day looking for my keys, and then I found them in the refrigerator. All right, so these kinds of things happen, and to my knowledge, my memory hasn't declined over the last few years. But people are concerned about doing things like this and worry that this could be the onset, especially of the family member of Alzheimer's dementia. So anytime someone is having memory issues, we do metabolic testing. You want to make sure you're not missing something treatable, like a thyroid dysfunction or B12 deficiency. We frequently do an MRI scan to see, is there hippocampal atrophy? Is there a mass lesion? Or has the patient had small strokes that would contribute to memory loss? And then we do, these are probably the two most common memory tests that are done, the MMSE and the MoCA. And we want to follow that at subsequent visits to see if there's a change. Very important that we inquire about sleep apnea or any features of sleep apnea, because if someone has sleep apnea, they're going to have some memory impairment. Okay, so again, we're looking for things that are fixable, and that would certainly be one where we can intervene. And then finally, it's very important to look at the patient's medications. And so I think this is high yield. We're going to kind of go through the common medications that cause memory impairment. So anticholinergics, really we try, if at all possible, to avoid these in patients over the age of 60 and 65, because they just cloud memory function. So the tricyclic antidepressants, which are very helpful for migraine headache prevention, but in older patients, they tend to cause confusion. Oxybutynin, we talked about that, acting on muscarinic receptors on the detrusor muscle for incontinence. Well, that has an anticholinergic effect in the brain as well, and so that can have some memory issues. Someone wears a scopolamine patch, they go on a cruise, and they may get confused because of the anticholinergic defect. And the anticholinergics used to treat Alzheimer's, like benztropine, trihexyphenidyl, and I told you we try to avoid these in patients with, did I say Alzheimer's? I meant Parkinson's. We try to avoid these in patients that have Parkinson's because of their cognitive effects. So remember, all of these anticholinergics, they're going to cause sedation and confusion potentially, but we'll look for other parasympathetic symptoms. So if we block the parasympathetics to the salivary gland, there'll be dry mouth, constipation, urinary retention. Antihistamines, which a lot of people take for sleep, like diphenhydramine. As you get older, that has a more profound effect on the brain. Opioids are big, oxycodone and others that would certainly impair memory function. And I see a lot of patients that have been on these types of medications for decades. But once they hit 65 or 70, now they're having some memory issues with it. So again, in the elderly, these medications are problematic. Benzodiazepines that can be taken for sleep or anxiety, such as Valium or diazepam, certainly clouds thinking. Okay, and just remember, so I mentioned the anticholinergics for the tremor of Parkinson's, but also from our last lecture, remember we try to avoid dopamine agonists like pramipexole, ropinirole in patients over the age of 65 with Parkinson's because of the encephalopathy that occurs. So psychiatric medications, neuroleptics, antidepressants, need to look at those very carefully. And next week we'll go over seizure medications, and so several of those can impair memory function, so those need to be looked at carefully. So when someone's having memory loss, it's a fair amount of work that you have to look through their medications, do a cognitive exam, do a careful neurologic examination. These are not short visits. Okay, so here are the different types of memory loss that we will go through in this lecture. And if you just guess Alzheimer's in someone that's having, an older person that's having progressive memory loss, you're going to be right 75% of the time or so. But the others that we'll go through all have distinctive clinical features. So kind of a rule of thumb for Alzheimer's dementia is that at age 60, the incidence is no more than 1%. So if someone's having progressive memory loss under the age of 60, it's probably not going to be Alzheimer's. Okay, but you can see after that, the rule of thumb is it doubles about every 5 years. So 2% at 65, 4% at 70, 8% at 85, and 32% at 85. Now this does not continue to go up exponentially, so it does level off. I mean, otherwise, you'd have 100% of people over the age of 90, 95 that get Alzheimer's. But overall, in people, the elderly population, you can see above this age that only 19 out of 160 of people over the age of 93 had no memory issues. Okay, so again, there can be a normal aging factor, but it's not very many people over the age of 93 that had really no cognitive issues. So Alzheimer's, again, it probably accounts for 70-75% of all dementia. And this is the cost in 2015. I didn't look up a more updated number, but it certainly is a major, not just medical, but financial issue. Okay, and also, people have called this kind of the ticking time bomb in healthcare because the over 85 population, that's the fastest growing segment of the population. So we're seeing much more Alzheimer's. So we'll talk a little bit about genetics. Most cases are sporadic, although if you have 2 or more first-degree relatives, then the risk does increase. And so what I'm going to go over now in the next few minutes, I would say is a newer understanding of Alzheimer's. I need to update the board review handout because I think for a lot of neurologists, the view of this has changed just in the last year or so with more evidence. So I think what we can say as a big picture is that in Alzheimer's you have a loss of the soluble form of amyloid beta protein. So this is amyloid beta 42, and a conversion to the insoluble form. Okay, but the most important thing is the loss of the soluble form. This is the normal, healthy protein. Okay, so when you lose that soluble form, that's when cognitive function occurs. Now, the usual way this has been described is to show this picture here, which shows that here, even before someone here's mild cognitive impairment, right? So this is like, we're going back decades. That an early finding is an increase in the cerebral spinal fluid of the insoluble amyloid beta 42. Okay, and so the usual model is that the amyloid hypothesis is that you have kind of this accumulation of this toxic insoluble amyloid that is destructive to the brain. But we need to point out, so that the usual model is this is a gain of function of proteinopathy, you have this toxic amyloid. But I think a better way of understanding it is actually to first recognize that the what you see here in this line is that actually even earlier than the rise in the insoluble form of the amyloid beta protein is that you have a drop in the soluble form of the amyloid beta 42 protein. Okay, and so I think a better way of understanding this really is to consider Alzheimer's as a proteinopenia from the loss of protein, because there are actually studies where you can see, even in patients that have a high insoluble form of the amyloid beta protein, if they also have a high soluble form, then they tend not to have dementia. So it's the loss of the normal soluble form that seems to be key. Okay, so again, as a big picture, you want to have, here's a healthy brain, you want to have the low insoluble form and the high soluble form of the amyloid beta 42 protein. What you don't want to have is the low soluble form, and the high insoluble form. So here's just kind of an illustration of this. We have a normal amyloid beta protein, but what happens here is when we move from a soluble to an insoluble form, this is essentially like a crystallized form of the amyloid beta 42 protein. It's non-functional. It's not toxic, but it's just not functional. That's the key thing. And so kind of wanted to illustrate this here is kind of think of milk that is curdled. Well, I mean, if you designed some sort of a drug to remove the curdling in the milk, is anyone going to drink that milk? No, you probably wouldn't. And so all of the studies, and there have been 42 of them to date, and probably more coming out in the next month, have been designed to design a monoclonal antibody that attacks the insoluble form of amyloid in the brain. And these actually are very effective at removing the insoluble amyloid beta protein, but patients don't get better. And so I think the toxic amyloid hypothesis is slowly on the way out. So, for example, here's one of these studies. And so look at this. The red here is the insoluble amyloid that is accumulating. And so here's a monoclonal antibody. This is just one of many studies where they've done this. And look, you can remove the amyloid, but these patients are not better. Okay, and it appears that they're not better because they don't have the soluble amyloid beta protein. Okay, so here, if we just look at this study and the amount of soluble amyloid beta protein, if that's high, then the probability of normal cognition is really good. Okay, if you have very little soluble amyloid beta protein, then your probability of having normal cognition is very low. Okay, so again, it's just strong correlation there. All right, so we have the amyloid precursor protein, which is good, normal, healthy. We have it at neuronal synapses. Appears to be important for synapse formation and repair. Probably facilitates ion efflux, and that gene for that is on chromosome 21. Now, in the abnormal situation, we have beta and gamma secretase cleavage, which leads to this insoluble form here of the amyloid beta protein. And that seems to be, again, I can't even take out all the old verbiage here. Here from last year, I told students that's the initiator of the damage. Well, yeah, you just see that as a marker, but and you do see those. That's what when you see senile plaques, you're looking at the insoluble amyloid, but it's really better understood as a loss of the soluble form. Okay, so then you have aggregations of these amyloid beta proteins, and again, in the older model, these are toxic, and I don't know, boards are still probably going to tell you that amyloid is toxic in the brain. Okay, so I maybe include this here just so that you're aware of the old thinking versus the newer thinking. But in a complex mechanism, tau ends up aggregating as well. So we have not only amyloid, but we have tau aggregation, and so these form the neurofibrillary tangles that are in the cytoplasm. Okay, and again, the idea here is there is a toxic component to the tau accumulation as well. And so one idea is that tau, its normal function is to stabilize microtubules, and so hyperphosphorylation there can lead to some of these aggregations of tau in the cytoplasm. So I had a medical student draw this to show you the amyloid precursor protein. Now, if we have the normal breakdown via the alpha cleavage, then you can see that cleaves right here. And so here you have the soluble form, which is not toxic. But if you have the beta cleavage, and here the gamma cleavage here, then you end up with the abnormal insoluble form of the amyloid beta protein, and then you can get oligomers. And the mechanism of all this is not well understood, but downstream this leads to tau accumulation in the neurofibrillary tangles. So kind of in parallel, you get the amyloid plaques and you get the neurofibrillary tangles. So Dr. Deich has gone over this with you, but just to remember that the amyloid plaques we see here extracellularly, and there are probably just some things from neuropathology that you just need to be able to recognize, and that is an extracellular amyloid plaque formation, tangle, which really just fills out the whole neuron. Okay, so here are the neurofibrillary tangles here. So they have the shape really of the neuron extending into the axon. So there are a number of genetic mutations which we rarely see, with some notable exceptions. So the amyloid precursor gene I mentioned is on chromosome 21, and there are more than 50 mutations, and these of the familial cases make about 10 to 15%, and these are really unusual. I've only seen a few of these in 20 plus years where we have a young onset Alzheimer's. So if you have someone that's Alzheimer's presenting in late 40s, early 50s, and if there's a family history, then that would fit for one of these genetic mutations here on the amyloid precursor gene, and we can do genetics testing for that. Now, trisomy 21 in Down syndrome, you have an extra amyloid precursor protein gene, and so virtually 100% of these patients will develop Alzheimer's by the age of 40. Okay, presenilin 1, again, encodes a protein here, presenilin 1 protein, and mutations here are more common than the amyloid precursor mutations, make about half of the early onset familial. And then presenilin 2 is just another one to consider that's less common. Okay, but even in these situations here, where more than 90% of the genetic mutations, these patients actually have a reduced production of the soluble form of amyloid beta 42 protein. So again, the key feature seems to be less the toxic form of amyloid and more the loss of the soluble form. So here's a graph showing you patients with Down syndrome. So they do overexpress the amyloid precursor protein, but they have significantly lower forms of the soluble protein. Okay, so here we can see in Down syndrome, here the reduction here in the soluble form of the amyloid beta protein. Now, I think quite important here, because this comes up a lot as people are doing their own genetics testing, like 23andMe, is to know about apolipoprotein. So these are involved in lipoprotein metabolism. They seem to bind and transport lipids. And so there are three isoforms. The one you want to have is the ApoE3, which is present in about 80% of the population. Appears to be probably protective against Alzheimer's dementia. What you don't want to have is the ApoE4 form. And so if you have two of these E4 alleles, then you have an 8 to 12 times risk of developing Alzheimer's by age 75. So when we think of ApoE4, these are the late onset Alzheimer's. And again, if you have two alleles, your risk is significantly increased. But it's important, we don't do this or recommend it in asymptomatic patients because it's a susceptibility gene, not a determinative gene. Okay, there are patients with two of these alleles that do not get Alzheimer's, not a guarantee. And even in the elderly, 40% of patients with Alzheimer's over the age of 75 do not have an ApoE4 mutation. Okay, there is a difference here in some ethnicities, so higher in the African American population. Now, the difference between the healthy ApoE4 and ApoE4 is really small. It's a single amino acid residue, but that you can see results in a pretty significant conformational change of the protein. Now, could not overemphasize this, that when we talk about stroke next month, or next week, and I tell you about a vasculopath patient who has hypertension, diabetes, dyslipidemia, they smoke. These are all of our major vascular risk factors. Yes, that does put you at a significant higher risk of stroke, but it also puts you at a very significant increased risk of Alzheimer's dementia as well. So vascular risk factors are also major risk factors for developing Alzheimer's. And so I thought a student here a couple of years ago drew a nice kind of diagram to show, epigenetic changes of lifestyle, and especially I would say vascular, that it can either accelerate or we move things in the right direction and decelerate. And actually, regular physical exercise, we probably have more evidence for that as being protective for Alzheimer's than anything else. And kind of closely tied into that, a healthy diet. There's good evidence that green leafy vegetables, a diet that is higher in certain fats, red meat, that kind of thing. This is a risk factor, so good healthy diet is important here as well. So there was a recent meta-analysis of 16 prospective studies showed a 45% reduction in Alzheimer's for those who were physically active on a regular basis, which I think was defined as breaking a sweat, 3 times or more per week. Okay, so breaking a sweat seems to be key, or getting your heart rate up for a good 20-25 minutes at least. Advanced education delays the onset of Alzheimer's, probably just have more synaptic density. Speaking multiple languages also seems to be somewhat protective, and playing a musical instrument, because you're really engaging a lot of your brain in that. When you're learning something, you're practicing a new piece, something like that. So basically anything that really stimulates the brain in a positive way, incorporating new information, is very healthy. So I won't go over the pathology very much here because that's Dr. Deish's area, but we do see diffuse atrophy with significant involvement of the association cortex, more than the primary motor areas, right? So patients don't have a progressive hemiplegia from involvement of the precentral gyrus, but the areas around the primary motor, sensory, visual, language cortex are involved. Okay, and I showed before that we get significant involvement of the hippocampus and the CA1 neurons especially. You also get a dropout of the basal forebrain cholinergic neurons. This is the so-called basal nucleus of Maynard, which produces acetylcholine. So there is overall a cholinergic reduction in Alzheimer's, which is why probably our most effective medications act by increasing acetylcholine levels in the brain. Okay, so again, the senile plaques are the extracellular, insoluble amyloid beta 42 protein, whereas the neurofibrillary tangles are intracellular, okay, and these include tau. And I'm sure Dr. Deich mentioned also the granulovacuolar degeneration in the hippocampus. So the earliest symptoms of Alzheimer's, as I mentioned, is anterograde amnesia, especially for episodic memories. So when you're talking with patients, you want to engage them, things they've done recently. Have you gone to a movie in the last month? What was it? Tell me about it. If they watch sports, ideally it's something you know a little bit about, but you can ask them what team they follow, what are the players on the team, how'd they do last year. Those would all be good ways of assessing for kind of episodic memories and anterograde memory loss. So working memory significantly impaired, and learning new things becomes virtually impossible a short time into Alzheimer's. It's very effortful. You get some device that needs to be installed from Home Depot, or a new electronic or something like that. Very difficult to figure out. Remember that semantic memories, these are preserved until very late. So they don't remember what they had for breakfast, but they could tell you what happened in politics 30 years ago, if they followed that, with a lot of detail. It's helpful to know that patients with Alzheimer's dementia, and this is true for most of the dementia syndromes, do not have insight. And so the usual story is the family member is bringing them in because they're very concerned. The patient is relatively unconcerned. Yeah, they don't see it as a big deal. The family will also tell you that, he used to be really active. He did woodworking. He used to go, fly motor airplanes with a club. He stopped doing that. Those kinds of loss of activities and hobbies is very common. Okay, so remember, aphasia is shrinking of a vocabulary, calling things that thing rather than using the specific word for it. Apraxias, I mentioned, so we want to look for that, ask questions, to the family member about that. If someone used to, cook or sew, they'll just describe, they kind of just seem to lose the ability to quickly chop an onion or sew a dress or, whatever other kind of thing that they would do on a routine basis. Driving a car, tends to be preserved until fairly late in Alzheimer's, but eventually, just the ability to kind of remember how to shift and use the brake and the gas is impaired. So agnosias we talked about. Spatial disorientation, remember the hippocampus is your GPS center, so they get lost early on. So here's just a typical encounter that I have had countless times with patients. We'll ask, what year is it? And, they tend to deflect. They don't want to highlight that they have a memory issue. So they may say something like, well, I'm retired. I don't pay attention to the date anymore. And so I'll say, well, that's okay. Give me your best guess. And 23. So don't give up if a patient says that. So what's the full year? 23. Okay, well, what year were you born? 1941. Okay, right, that's the full year, 1941. What's the full year now? And they may say it's 1923. So they do a pretty good job, actually, of hiding their cognitive deficits. So you need to kind of really get into the depths a little bit to uncover this. So judgment is impaired, problem solvings deteriorate. I mentioned things like doing the finances, doing taxes, just can't manage that anymore. But social skills are preserved until relatively late in Alzheimer's. And these patients come in, they're jocular, they're telling jokes, they're outgoing, and superficially, you could think that that things are pretty normal. But when you get down into the gritty details and ask them some specific questions, they do poorly. Now, perseveration is a common feature in Alzheimer's. What that means is patients will fixate on something, and that may even happen during the exam. Like they may I say something and they keep coming back to that over and over again. Or I have a patient with Alzheimer's. He passed away recently, but for years he came in and told me the same dirty joke. And sometimes he would tell me the same dirty joke 2 or 3 times in the same visit. So that would be an example of a perseveration. In later stages, they go from being kind of outgoing, jocular, to being more apathetic and withdrawn. And depression, anxiety, behavioral symptoms become much more problematic the further they are into the condition. And then we get agitation, restlessness, delusions, the spouse is having an affair, hallucinations, and these are very distressing. Okay, so especially in the later stages, behavioral symptoms are what is really a significant burden for the family. So as a very late stage of Alzheimer's, patients can kind of look Parkinsonian. Their gait slows down, they fall, but this just reflects the whole degeneration of the brain. This does not tell us that the patient has Parkinson's disease. So we can say, they have some Parkinsonism, but this is just due to Alzheimer's dementia. And remember, we'll check our frontal lobe release signs, the glabellar sign, palmomental, the grasp reflex. These are all things that we would expect to find, some of them in patients with Alzheimer's dementia. And in the end stage, the patient is, in bed, not responsive, doesn't recognize the spouse, is nonverbal. Mechanism of death is usually just the body becomes weaker, can't fight an infection. So pneumonia, bladder infection, someone falls and gets a hip fracture. It's often a bunch of things that kind of come together like that. So the diagnosis of Alzheimer's is a clinical diagnosis. So I like to, need to have the family there because you want to know when was the patient last normal, and then kind of work from there and kind of get the progression. So again, specific questions that are very helpful. Who takes care of the bills? Who prepares the meals and cleans the house? And if something changed, what happened? Is there a loss of interest in previous activities? Ask about driving, because you'll often get a story, we took his keys away a few months ago, and then there'll be a story about something that happened. Perform cognitive testing, one of the cognitive tests, and just recognize that patients with Alzheimer's may easily get frustrated doing that test. So you may need to backpedal into just engaging them in conversation about sports or movies or things that they've seen recently to try to get some information that way. So if we do an MRI scan, we're looking for atrophy, but especially involving the hippocampus. These other tests are still mainly done for research purposes, so we can do PET or SPECT scan to look at metabolic activity, and PET amyloid imaging, which is very, very useful for diagnostic, but still just not readily available. And then Dr. Deich will tell us we're wrong at autopsy. Hopefully not very often, but then we can confirm at diagnosis. So remember that just the brain shrinks in Alzheimer's, but most helpfully look here at the big temporal horn at the lateral ventricle. Look at the small hippocampus compared to the normal hippocampus here. Okay, so again, if you have a patient with mild cognitive impairment and this is what the MRI looks like, they have Alzheimer's. And here's a more subtle case I showed before, showing you the enlarged temporal horn of the lateral ventricle. So PET scans show hypometabolic activity, especially we can see here in the parietal region. But these are really just, again, something that's done at research. And amyloid studies here showing the insoluble form of amyloid would be extremely helpful if these were just available at every institution, because it would be a very, very sensitive test here for the diagnosis. So does everyone need an MRI scan? Well, probably most neurologists are going to order an MRI scan in someone that is having memory loss. But certainly, you want to do a careful neuroexam. If your patient with memory loss has a little bit of right-sided weakness, or has a pronator drift, or has a visual field deficit, well, they definitely need an MRI scan because maybe it's a tumor or something masquerading as Alzheimer's dementia. Okay, I won't ask you the specific tests, but just to know, we do a lot of metabolic tests. We don't want to miss something like a B12 deficiency that is mimicking as Alzheimer's dementia. In general, most patients die within 6 to 12 years of the onset, but the range is big. Some patients can live, I followed for years a pediatrician who had Alzheimer's for well over 15 years and was really functional, quite functional for the first 10 years with Alzheimer's. So there are 3 FDA-approved medications that act as an acetylcholinesterase inhibitor. Remember, if we do that peripherally, that's the mechanism of pyridostigmine for myasthenia gravis. But these act in the brain, so they boost acetylcholine levels in the brain. And I think the one you need to know for boards is donepezil. I highlight rivastigmine because we're going to come back to that in another type of dementia syndrome. And so these medications, I would say, provide a modest benefit. I mean, generally patients don't come in saying they're a lot better, or family members, although I've heard that. But it does seem to patients just do a little bit better overall on these medications. So it's a mild benefit. You don't only increase acetylcholine centrally, there is some peripheral effect as well. So just like with pyridostigmine, you can get stomach cramps, some diarrhea, nausea, vomiting from that. Mantidine is a medication for moderate to advanced Alzheimer's. It may act mainly against an NMDA receptors, so it has an effect against glutamate, an excitatory neurotransmitter. Very mild possible benefit in moderate to advanced Alzheimer's. Okay. And then just remember that you want to be aware of the behavioral symptoms that are so common in the later stages of Alzheimer's. Treat the depression, the delusions, because that'll just make things much more bearable for family members. And so again, we like to use in neurology atypical neuroleptics like quetiapine because these patients do tend to develop a little bit of Parkinsonism, and so quetiapine is less likely to be problematic there. So here are a lot of things, no proven benefit. Anytime in neurology or just in medicine when we have something that we just don't have great treatments for, people are going to go off and unfortunately waste a lot of money on things that are of no proven benefit. And so all the time I get people come in with an advertisement or a newspaper clipping and they want to know if this is helpful. Okay, you do not need to know this, but since this is kind of the hot information recently, lecanemab was FDA approved in January 2023. This is another one of the monoclonal antibodies against the insoluble amyloid beta form. And a lot of neurologists were upset about this because the things that are stated, like a 27% improvement and things like that, is really overstating, I think, significantly the benefit of lecanemab, which is not a benign medication. We see frequently these what's called ARIA, or amyloid-related imaging abnormalities, which are microhemorrhages or edema in the brain, and these are quite common. And actually, the brain had more atrophy in lecanemab than patients that were on the placebo. And so, but it is going to be a hot issue. Already we're seeing a lot of people coming in who are anxious to receive this medication. And so that involves a lot of patient education. Okay, let's stop there. And then in the next lecture, we'll go over all of the other dementia syndromes.